Speaker is Dr. Sharon Henry, an expert in cardiovascular health. Yes.
So good morning, and if this is going to Ghana, good evening. I'm really happy to be here, and I'm going to talk to you a little bit about cardiovascular disease, its risk, from both a global, but more so from what's going on in the US, as well as what's going on in Ghana. If this would move, that would even be better. Thank you. So, get rid of that on the bottom. So, can you also help remove that? Just to give you a little bit of a perspective, I'm Vice President of Global Medical Affairs for Bristol Myers Squibb for cardiovasculars and metabolics, which gives me a global view of cardiovascular disease. However, I just want to say that this isn't really a talk about the company or its position around cardiovascular disease, but what I will be talking to you about is that I'm also a member of the Board of Directors for the American Heart Association and one of its past chairs for one of the affiliate boards, and so I am going to express some of what we believe at the American Heart Association is really pertinent to cardiovascular disease and wellness. Okay. So I thought I'd start out with maybe something to just raise awareness a bit. And I wanted to talk a little bit about the global epidemic of cardiovascular disease. And I want to say that just to start off because often we think about cardiovascular disease as something that affects very affluent or developed countries, that it's a disease of older people, and it's a disease that affects primarily men. And I'm going to tell you all of those myths are not true. Last year, September, was actually quite interesting. It was on September 11th, 2011, that the World Economic Forum held a meeting at the UN, and it was to talk about the increasing risk of non-communicable disease in developing countries. And by non-communicable diseases, it includes cancers, but equally importantly, and I'm going to show you just a few statistics because I think it helps put it in context for you, that cardiovascular disease and some of the associated morbidities like diabetes are epidemics around the world. And it's not only a problem for the individual and that it's causing increasing death and morbidity, but it's also taking an economic toll on us globally. And it's estimated that $47 trillion are going to be spent over the next 20 years, equal to 75% of the global gross domestic product in management of these diseases. Unhealthy lifestyles, urbanization, I'm going to talk a little bit about what we can do to change some of these statistics. Prevention is the key, and it starts with the individual. So, if you could go to the next slide. There is a transitional shift. Now, yes, developed countries, US, Europe, primarily have the brunt of cardiovascular disease, but I will tell you that it's the low and middle income countries that are developing that are actually at a higher risk, and they're accountable for 80% of the deaths that are going to occur from cardiovascular disease over the next several years. 25% is occurring in very young people. Now we're seeing cardiovascular disease. Remember I told you the myth that we thought it was older people? We're seeing it occur at a much earlier age. And 48% of healthy life loss are in the most productive years, in the ages of 40 to 50 years old. And that it's expected to soon eclipse, in developing countries, more people are going to die of cardiovascular disease than communicable infectious diseases. Go to the next slide. So I just wanted to show you how that breaks out. So in that 30% in blue, that's cardiovascular disease, heart disease and stroke. The 30% in red, that's communicable diseases. So that's diseases due to infectious causes, nutritional deficiencies, and maternal deaths. Right now, cardiovascular disease in developing countries is equivalent to that. And diabetes, which you see is a small percentage, is increasing as well, especially in kids. If you go to the next slide. Now, I just wanted to show you this, and this is just to show you that there are actually 4 stages that countries and nations go through as we move from areas of where infection is the most common cause of the disease, and the stage pestilence, famine, it's really predominated by malnutrition, infectious diseases, and you can see then that life expectancy is shorter. Average life expectancy is around 35 years, but the results of cardiovascular disease, the numbers of people that die of that, are low. And those that have cardiovascular disease is actually related to infection, rheumatic heart disease, which is caused by a streptococcal infection that's not adequately treated with penicillin. And that's where a good percentage of sub-Saharan Africa happens to be, in parts of regions where there are more infections going on. As you move through these stages, you get towards more man-made diseases. And by man-made, I mean that they're a result of our lifestyles. They're things that are preventable. Degenerative and man-made diseases result from the fact that our diets are changing. We've taken more saturated fat. We are gaining weight, more smoking, and that's resulting in more cardiovascular disease. A life expectancy is longer because we're not dying of acute infections, but we are dying of chronic cardiovascular diseases. If you go to the next slide. So, in taking a look at sub-Saharan Africa, they're actually in 2 phases of our risks here. One is around, there is continued risk around communicable diseases. We heard this morning about HIV. We're actually getting improved rates in the treatment of that, but other infections. But we're now moving into the stage caused by lifestyle changes and moving from rural areas into urban areas where we're seeing this increased morbidity and mortality and loss of life in younger ages due to cardiovascular disease. If you go to the next slide. So, I just wanted to show you one study that was actually done in Accra, in Ghana. It's a few years old, but what they did was they really wanted to look at what's the origin, what's causing cardiovascular disease, and they followed about 700 patients over a several-year period, and what they found was the risks are no different to the types of cardiovascular disease-related causes we have in developed countries, right? So hypertension, congenital heart disease is still a problem. Coronary artery disease, however, is the most frequent cause. What's different was that the average age of where people were dying or having an effect was 40, in the 40s. We're here in the developed countries, it's in the later years. Coronary artery disease tended to be a little older, people that were in their 60s. Women and men were likely affected, although there's still slightly higher, more men than women. But the risk factors, hypertension was almost 66% of people had underlying hypertension. And the thing that was the most disturbing about it is that we were seeing patients in the ages of 20 to 26 with hypertension. Very young people. Smokers were still high, almost 12%, and high lipids, a little less than what you'd see here in the States. Rheumatic heart disease is still a problem. Go to the next slide. So, I did want to take a moment to just talk about, well, what is cardiovascular disease? I've been throwing around this term. Most of you may know it, but I just want to make sure everybody understood what I was talking about. So, it's any diseases that affect the heart or the circulatory system, the arteries that are going to any major organ like the brain. So if I cut off blood supply to the brain, that causes a stroke. The majority, over 80%, is due to coronary heart disease, hypertension, and congestive heart failure, where the heart is really, muscles been damaged so that the heart's not able to really pump blood out efficiently anymore. Cardiovascular disease is the number 1 killer, it's 30% of all deaths, and I'll talk a little bit more specifically about women in a minute. And time that this statistic was taken, and the numbers are only increasing, cardiovascular disease was responsible for about 17 million deaths in that year. So, coronary artery disease, the most common form or leads to a heart attack. What is going on? Well, I'll tell you what's going on. On the left side, that's a normal artery. Nice, smooth lining of the artery wall. But in a diseased artery, what's happening are 2 things. One, you see that yellow area, that's fatty deposits or cholesterol deposits that are laid down in the artery. Now that's bad enough, but what also happens when that fatty deposit is laid down in the lining of the artery, it causes a rough surface. And as the blood passes through that, it causes a clot to form. If you've ever cut your finger and you see a blood clot form, the platelets are the little cells within the blood that cause that clot to form. That's also what's happening within the artery. And if that clot gets big enough, it can block off or occlude or keep blood from flowing through the artery. And when that happens, if you go to the next slide, that white line there, that's an artery that no longer has blood going through it. And as a result of that, that dark area, this area, that's necrosis. That's where the heart muscle has died. If we can get to it soon enough, this blockage that's occurring somewhere up in here, we can relieve it, get it, and people, you've heard of stenting and other ways that we can go in and open up a blocked vessel. If you can do that before this happens, you can save or salvage some of the heart muscle wall. If that doesn't, that muscle's dead and we can't bring it back again. That's a heart attack. Now, there are differences. I just want to talk a little bit about ethnic and gender disparities. There are differences. Now, we've all heard that the risks and deaths from cardiovascular disease are decreasing in this country. That's true overall, but not if you happen to be an African American man or woman. These are the statistics from the National Vital Statistics, the NHANES report, which shows that African American men and women have higher rates of death due to cardiovascular disease than non-Hispanic whites. Go to the next slide. In women, it's even more of an issue. Heart disease, it continues to be the #1 killer of women, and the #3 is stroke. We heard cancer #2. Each year, almost 9 million women globally die of heart disease and stroke. It's greater than the total numbers of deaths affecting and diseases affecting women, including cancer, tuberculosis, HIV, AIDS, and malaria combined. This is in the undeveloped countries as well. And yet it's largely preventable. And that's the message that I'm going to talk about for the rest of this talk primarily. If you go to the next slide. I do want to tell you two things because it affects people of color differently. African American women are 35% more likely to have a heart attack. Hispanic women, they have earlier onset. And a lot of it's driven by risk factors, which are lifestyle. Things we can do something about, including obesity, high cholesterol, physical inactivity, and most important, I think, is education and information. Whether you're here living in the United States or you're in Ghana, education is key and prevention is the tool. If you go to the next. So I just wanted to talk about, I talked about the US. Here's the risk factors for women in sub-Saharan Africa. Hypertension, once rare, is now occurring not only more frequently, but in younger people. The prevalence of obesity is increasing significantly. And it's being driven primarily by the increase in women. In the past decade, it grew 114%. And in a sample of young adults, we were seeing about 50% of women in sub-Saharan Africa were overweight or obese. And in one study, there was a significant odds ratio increase that you were going to become obese or overweight and have a high hip-to-waist ratio. What do I care if my hips are smaller than my waist? The reason we care is because where fat is deposited and the type of fat it is increases your risk for having heart disease. And it is in this central area, it's called central adiposity. The fat cells there, the amount of fat around your viscera, the amount of fat around the heart is related to where those fat deposits are. And that's why it's important for us to get our waist-hip ratio down. Good. So I just want to talk about a few things that we need to be ever mindful of. I don't have to tell this group because I already know you know this. But 6 major things need to always be top of mind because these are things that we can control. It's tobacco use and exposure to tobacco. It's our weight, how physically active we are. Get off those couches and get out and walk. It's high blood pressure, high blood cholesterol, and risk of diabetes. And we can manage those things, ladies and gentlemen. So, what can we do? I've been telling you all this doom and gloom. What can you do? Well, we can do a lot. So first of all, know your numbers. Know that a blood pressure, the optimal blood pressure, is less than 120 over 80 millimeters of mercury. If your blood pressure is high, there are guidelines that suggest if it's over 140 over 90 that you should get treated. And if you have diabetes, because your risk factor goes up for cardiovascular disease, if you have diabetes in addition to hypertension, we like to get that even lower, less than 130 over 80. Your blood cholesterol levels, it's important to know your numbers. Your LDL cholesterol should be less than 100. Your total cholesterol should be less than 200. Triglycerides, women, less than 150. And HDL greater than 50. That's the good cholesterol. And then if your lipid levels are higher than that, we need to get them down, and often medication in addition to lifestyle. Diabetes, lifestyle, changing what we eat, how we eat, and also if hemoglobin A1C, which is a measurement of how long your blood sugars have been elevated, is above 7, and we are not able to control it with lifestyle and diet change and exercise, going on to therapies with medications. What can you do? Well, you can calculate your risk. The American Heart Association, we have as a part of Go Red for Women, which I'll talk about in a minute, which is a national campaign in the U.S., has focused on understanding your risk. There's a simple quiz you can take, we all can take, which helps us define our risk. And what we found is that most women have one or more of these risk factors. Two things are not modifiable, meaning we can't do anything about it. It's how old we are and our family history. So age and sex, a simple question is, I'm a woman greater than 50, or I've passed menopause, or I've had my ovaries removed. Family history, my brother or father or some relative has had cardiovascular disease in the past. Blood pressure, higher than the rates that I talked about, 140 over 90. Tobacco smoke. I smoke, or I live or work with people who smoke tobacco regularly. Environmental exposure to tobacco is or smoke rather, is also an environmental hazard, and it puts you at a higher risk for developing cardiovascular disease. The important thing to know too, that when you stop smoking, after 3 years, your risks go down to if you had not smoked at all. So that's important to know, that you can stop and you can change your course. You need to know about physical activity. If you take less than 30 minutes of physical activity a week, that's a risk factor. Being overweight, if you're more than 20 pounds overweight for your height or build. And then diabetes and your heart medical history. If you've ever had a coronary heart attack or a heart disease before, or an abnormal function of the heart, or diagnosis having a heart attack, you're at risk for having another one, and then a stroke history. Can you go to the next? So, what can you do? The other thing we as women really need to understand is the signs and symptoms of a heart attack. Well, it's pain in the chest, right? Well, yes, but not always. Not if you're a woman. And I've talked to many patients who've said, you know, I just wasn't feeling right, and I felt really bad, and I thought it was a flu, and I just put it off, and I just was really dragging down and on and on and on, and she ended up having a heart attack. She was in the middle of expressing an underlying problem, that you can have pain in the neck, or the shoulder, or the upper back. Sometimes it radiates to the back or somewhere in this area. Nausea or vomiting, shortness of breath, sweating, lightness or dizziness. Unusual, this was the one case that I was talking about, unusual fatigue for her. Never ignore a symptom. I will say that again, never ignore a symptom, because often as women, we ignore our own health. I talk to so many people who have been survivors that are part of our Go Red campaign who've said, well, you know, I just had to take care of the kids, and I had to go pick up this, and I didn't think it was anything, and it happened in the middle of the night, and I didn't want to be a bother. I didn't want to call 911. I didn't want to disturb anyone. never ignore a symptom. If it bothers you, check it out. Because what you don't know and what we don't do can have a negative impact. So our diets and lack of exercise, and equally important, in a couple of studies I found that often women of color don't really trust the information we're getting, so we need to seek it out. And also in undeveloped areas, we need to be able to deliver the education, because the education about the signs and symptoms and what you can do in lifestyle is key. And ladies, I will tell you from personal experience, the hardest thing we ever have to do is change our behaviors. But we got to work on that. We can't trivialize risk. I've heard patients being told, oh, it was just a little touch of sugar. It's never a little touch of sugar. We have to be culturally sensitive to the role of the family, and we as women, because we make a lot of the health decisions. Whether you're here in the US or you're in Ghana, women play a very important role. And also, one shoe fits all. We can't always think that how we recommend changing behavior fits everybody irrespective of where you are in the world. And there is one, and the family is really important to doing that. The next. So, here's some recommendations of what you can do personally to take charge. Cigarette smoking. Don't smoke or avoid areas where smoke is present. Get at least 150 minutes per week of some sort of exercise. 75 minutes of it can be vigorous exercise. Get out and walk. I do really emphasize that, not only for us as women, but for kids. Because kids are far too often not exercising and getting out anymore. Dietary intake. Choose a diet rich in fruits, vegetables, whole grains, high fibers, not refined sugar. Complex carbohydrates are important. Everything in moderation. Limit the intake of any saturated fats. Food is you really read the labels. Trans fats, no, stay away. And modify how much alcohol and sodium you take in. And then try to maintain, you don't have to be supermodel skinny, just to maintain a healthy weight. Next. Here's something we need to take a look at, which is looking at, there's an individual level we can do something, and then there is a governmental level we can do something about it. In 2010, the Institute of Medicine issued a report which really focused on how we globally can create opportunities to decrease cardiovascular risk and death and morbidity. And it was only two things: creating environments that promote heart-healthy lifestyles, and then building public health infrastructure and health systems. That doesn't mean, because we do have to make choice around how resources, especially when resources are limited, how we use those. There were 4 essential functions. One was that unilateral and multilateral agencies have to advocate that cardiovascular risk and focusing on cardiovascular disease is an area we need to put top of mind. We need to build evidence-based and locally relevant solutions, which really just meant we need to be understanding the environment we're taking our recommendations into, and focus on simple things first, like education and lifestyle change. Disseminate and talk about what's working, and then collaborations. And I'm going to talk about a couple that are going on now in Ghana, which I think are important. Go to the next slide. Well, no, I'm going to do this one first. There's 2 ways to really focus on this. One is at a goal of determining what's the social impact, what's going on in the environment, and how can we help decrease with interventions that will affect the health of society or the nation that you're in. Some examples are taxing tobacco. We found that when you put the tobacco and raise the tax on cigarette, people do stop smoking or decrease smoking. Subsidizing with healthy foods. Health education is probably number 1, because that doesn't cost a lot. And then making sure we're promoting physical activity. Focusing on the individuals. Prevention. Identifying and treating individuals with high cholesterol and hypertension, and smoking cessation programs. And then finally, for those who've manifested appropriate treatments if you are at risk and have had a cardiovascular event. Next slide. This is what I wanted to talk about in terms of partnerships. There are a couple that I thought were noteworthy that are going on in Ghana now. One is non-governmental organizations or NGOs. The Ghana Heart Foundation, which is a non-profit, non-governmental organization, which is focusing on bringing partnerships together to really help decrease and proliferate public education and to find dollars for research of how we can really manage cardiovascular disease. I did leave their website up. And then the Ghana Society of Hypertension and Cardiology. Church-based organizations are really important too, the community health workers, because within the church, when you come to church, it's been done here in the U.S. and it's also being done outside the U.S. Lay workers can play a major role in helping communicate and educate and telling people about what they can do to really improve their cardiovascular health. Go to the next. I'm going to go through this quickly. Go Red for Women. Got my little red dress pin on here. The American Heart Association, the National Heart, Lung, and Blood Institute have focused on raising awareness in the United States around cardiovascular disease in women, and we've called it the red dress. Why the red dress? Because I look good in red? No. Because it's a symbol of power, and we want to empower women to take back control of your own health. Go to the next slide. So, the American Heart Association Go Red campaign has been in effect now for a little over 6 years. In 2003, we were faced with a challenge, and now 500,000 women in the United States were dying unnecessarily of cardiovascular disease. For all the myths that I've talked about, and in a short period, we've raised it from a grassroots effort to one that has vibrant national impact. If you go to the next slide. So, a couple of facts, not to belabor it. 90% of all women have one or more risk factors we found for cardiovascular disease, but the majority didn't know it. That was the problem. Majority didn't know it, and if you don't know it, you can't do anything about it. The second was more women were dying of this disease, and we could do something about it. We, meaning all of us here, all of you that are listening, and everyone that really is affected by it. 43% of African American women and 44% of Hispanic women knew that heart disease was their greatest health risk, compared with 60% of Caucasian women. 26% of women die within a year of suffering a heart attack. What a life lost. Right? And while 1 in 31 American women dies from breast cancer each year, 1 in 3 dies of cardiovascular disease. And this is not to say, well, my disease is more important than your disease. Absolutely not. It means that there's some preventive things we can do about it. Go to the next slide. So, why Go Red? Go Red was designed to do 3 things. 1, connect and empower women, educate women, and making sure we help women take action that they could own to change their risks. If you go to the next slide. So, I just want to tell you some of the results with education that you can achieve. We found that recognition amongst women with education went up. So if you tell people the information, you give them access to the information, they can take action. 89% of women have joined some of the Go Red movement, which means they're taking more action around in utilizing some of the information to change their lives. We've raised money. $200 million has been raised for education and conferences, and then $44 million has gone to research projects of how do we focus on women. Because when I went to medical school, I was taught that this is something we needed to think about for men and not so much women. And I ain't that old. So, thanks to Go Red, female cardiovascular deaths have decreased from nearly 505,000 lives lost in 2003 to 419. So we've decreased significantly, but there's still a long way to go. And that means that almost 100,000 women are living today that would not have lived if they hadn't had the education. And that is really what's key. And I would say that whether you're in the United States, Europe, Sub-Saharan Africa, wherever you are, you need to know your risk factors, you need to know what you need to do about them, and then you need to act. Act is the key. And so that's what you can do. Visit Go Red for Women, understand your risk factors, take the 1-minute quiz, and understand that you are empowered to take charge of your life. Thank you very much. That is wonderful. Thank you so much.
For what?